Welcome back to the Deep Dive. Today, we are doing something that I know a huge portion of our audience has been clamoring for. We're moving away from the abstract and the theoretical, and we are landing right in the trenches of clinical practice. We are opening up the heavy artillery. Baily loves short practice of surgery.
The irony, of course, being that there is absolutely nothing short about it.
Not at all.
It's a tome. It's a doorstop. But for a surgeon or, anyone aspiring to be one, it's practically scripture.
And we're being very specific. We're cracking open the 28th edition, chapter 787. The topic is the large intestine.
A big one.
It is. Now, before we cut the first incision here, I need to set the stage properly. This deep dive is designed as a ready reckoner. It's a revision companion.
Right.
We are going to interpret this dense, sometimes intimidating chapter and give you the mental anchors you need to retain these critical concepts.
But, and I cannot stress this enough, this is not a replacement for reading the book.
Absolutely not.
We are interpreting the text to make it digestible, to give you the narrative arc of the colon, if you will.
I like that.
But for the fine print, the specific drug dosages, the staging tables, and those beautiful high-resolution pathology slides, you must go back to the source.
Yeah.
Consider us your study buddies who've already stayed up all night highlighting the best parts so you don't have to start from scratch.
Exactly. We're the high-yield highlighter.
Yeah.
Our mission today is to take you on a journey from the ileocecal valve all the way down to the rectum.
The whole trip?
The whole trip. We're covering anatomy, the big C, cancer, inflammation, and the emergencies that keep registrars awake at night.
Mm-hmm.
And we're going to use metaphors.
Yeah.
Lots of them. Because if you can visualize the mechanics, you don't have to rote memorize the text.
I'm ready. I'll be the attending surgeon today, synthesizing the information and asking the hard why questions.
And I'm ready to be the inquisitive medical student, asking the questions that everyone is thinking but might be too afraid to ask during ward rounds.
Let's do it.
I could definitely play that role.
Yeah.
So let's open up the patient, metaphorically speaking. Section 1, the anatomy and physiology landscape.
Okay.
When I look at the large intestine in the textbook, the dimensions are confusing. Baily and Love says the colon is about 1.5 meters long.
Right.
That's a significant length of tubing. But then, in the same paragraph, it says you can reach the cecum, the start of the colon, with a colonoscope inserted only 70 to 90 centimeters. How does that math work? Where does the rest of the bowel go?
That is the first visual anchor you need to lock in. It's what we call the concertina effect.
The concertina, like the instrument.
Exactly. The colon isn't a rigid pipe like a copper plumbing tube in your house. It's like an accordion or a concertina. It's mobile and it folds up on itself.
Oh.
That's why a scope can traverse a 1.5-meter organ with less than a meter of insertion. As the endoscopist pushes, the bowel literally pleats over the scope, shortening the distance.
Okay, that makes sense. It's dynamic. It's not static.
Not at all.
Now, let's say I'm in the operating theater. I've opened the abdomen, and it's just a mess of pink loops.
Mm-hmm.
To the untrained eye, it all looks the same. How do I instantly know, okay, that loop there is colon, and that loop over there is small bowel? Baily and Love lists specific identifiers.
You look for the fingerprints of the colon. There are 3 specific features that distinguish it from the small bowel. First and most obvious are the tinea coli.
The tinea coli?
Yes. The small bowel has a longitudinal muscle layer that, wraps around the entire circumference of the tube.
Right, a smooth coat.
A smooth coat. But in the colon, that longitudinal muscle is bundled into 3 distinct bands running along the length of the bowel. These are the tinea.
I've heard the sweatpants metaphor for this, and it always stuck with me.
It is the best way to visualize it. I mean, imagine the colon is a pair of very baggy sweatpants.
Okay.
The tinea coli are the drawstrings. But here's the catch. The drawstrings are physically shorter than the fabric of the pants. So what happens? They gather the fabric. They pull the colon up into these sacs or pouches.
And those pouches have a name?
They do. Hostrations, that's the second identifier.
Right.
That's why the colon looks bumpy and segmented on an X-ray, almost like a string of large beads.
Whereas the small bowel looks smoother, or you see those lines going all the way across.
The valvulae conniventes, exactly. They look like a stack of coins. Haustra only go part of the way across the lumen.
So sweatpants with tight drawstrings create hostrations. And the third identifier?
Appendices epiploicae.
Which sounds like a spell from Harry Potter.
It does, doesn't it? They're just little tags of peritoneum filled with fat hanging off the surface of the colon, mostly on the left side.
So if you see fat tags,
it's colon. If it's smooth and has no tags, it's small bowel. Simple as that.
Drawstrings, pouches, and fat tags.
Hmm.
Got it. Now let's move to the supply lines. The blood supply. This seems to be where the text stops being just anatomy and starts becoming surgical strategy.
It is the most critical part of colonic surgery. It really is. If you don't understand the blood supply, you can't operate on cancer, and you can't understand ischemia.
So you have two main power grids here, right?
That's right. The superior mesenteric artery, or SMA, and the inferior mesenteric artery, the IMA.
This goes back to embryology, doesn't it?
Yeah.
The midgut versus the hindgut.
Precisely. The SMA covers the midgut embryologically, that's the cecum, ascending colon, and the first 2/3 of the transverse colon.
Yep.
The IMA covers the hindgut, the last third of the transverse, the descending colon, sigmoid, and rectum.
And they meet in the middle somewhere.
They do. The SMA sends out the ileocolic, right colic, and middle colic arteries. The IMA sends out the left colic and sigmoid arteries, but the magic happens where they connect.
How so?
There is a continuous vascular arcade running along the border of the colon called the marginal artery of Drummond.
The marginal artery of Drummond. It sounds like a refined British pub or perhaps a classic detective novel.
It kind of does. It acts like a ring road around a city. Or maybe a better analogy is a backup generator.
A backup generator.
Okay, it connects the SMA system to the IMA system. This is crucial because if one road gets blocked, say, by a plaque or a clot, blood can usually travel around the ring road to keep the tissue alive.
Usually.
However, there is a flaw in the design, a bit of a danger zone.
A design flaw. In the human body.
It happens. It's the splenic flexure, that sharp turn under the spleen on the left side.
Okay.
This is the junction between the midgut and the hindgut. It is what we call a watershed area. The vessels here are the furthest away from the main power source on either side.
So it's the end of the line for both power grids. It gets the weakest signal.
Exactly. If a patient has sudden low blood pressure, maybe they go into shock, have a heart attack, or, run a marathon without hydrating, this area dries up first.
I see.
It's the last to get blood and the first to lose it. That is where you get ischemic colitis.
That's a great clinical pearl. Low BP plus left-sided pain equals ischemia at the watershed.
Got it in one.
Now, speaking of arteries, Baily and Love talks about the high tie in cancer surgery. This sounds like a fashion choice, but I assume it's not.
Far from it. This is pure oncological strategy. When we remove a cancer, we don't just cut out the piece of bowel with the lump. We have to take the blood supply that feeds it.
Right.
We ligate, or tie off the artery, right at its origin high, up near the aorta. That's the high tie.
But why go to the trouble? I mean, why not just tie it off near the bowel where it's easier to reach?
Because of the lymph nodes. You have to visualize the lymphatic drainage as a tree with the artery as the trunk.
Okay.
The cancer cells spread through the lymphatics, which run alongside the arteries. If you want to pull up the weed, the cancer, you have to get all the roots.
And the roots are the lymph nodes.
The roots are the lymph nodes. If you leave the main trunk of the artery, you leave the central lymph nodes, which might contain cancer cells.
So high tie equals better lymph node harvest, which equals better staging and hopefully better survival.
Correct. It's about clearing the entire field.
Before we move on, let's do a quick check-in to see if we're tracking. I want you, the listener, to pause for a second and think about this.
Let's do it.
If a patient comes in with vague abdominal pain, and they point specifically to their belly button, the periumbilical region, and say, "It hurts here," which part of the colon is likely involved?
Think back to the nerve supply in embryology. The visceral pain from the midgut, which is supplied by the SMA, is referred to the periumbilical region.
The middle part of the gut refers to the middle of the abdomen.
Exactly. So that would be the cecum, ascending colon, or transverse colon.
And if the pain were suprapubic, low down.
That's hindgut IMA territory. So you're thinking sigmoid or rectum.
Perfect. Midgut is middle, hindgut is low. If you didn't get that, rewind and listen to the embryology bit again.
Do it. It's important.
Moving on to section 2, the polyp pathway. I feel like polyp is a word patients hear and immediately panic. But Baily and Love is very specific about the definition.
Yes, and this is important. Polyp is just a clinical description. It literally just means a protrusion. It doesn't tell you if it's good or bad.
Just a lump.
It's just a lump on the lining.
Right.
Our job is to figure out if it's an innocent bystander or a ticking time bomb.
The text differentiates between the innocent and the suspicious. Let's break those down.
On one hand, you have metaplastic or hyperplastic polyps. Generally, historically, these are the good guys. They're usually benign, just an overgrowth of normal cells.
Use you.
However, and medicine always has, however, recent data shows that some large hyperplastic polyps, specifically serrated ones, can be dangerous.
Why serrated? What does that mean?
Because under the microscope, they look like the teeth of a saw. These are tricky because they're often flat and hard to see, but they carry genetic risks like BRAF mutations.
Okay, so hyperplastic is usually okay, but watch out for the big saw-toothed ones. Then we have the adenomatous polyps.
The troublemakers. These have malignant potential by definition. We classify them by shape tubular, which looks like a test tube, and villus, which looks like shaggy carpet or finger-like projections.
And which is worse?
Think of villain.
Ah, I like that.
Villus adenomas are much more likely to turn into cancer than tubular ones. The shaggier it looks, the more dangerous it is.
Villus is villain. Got it. Now, is there a size cutoff where you start to really worry?
The magic number is 10 millimeters or 1 centimeter.
Okay.
If a hyperplastic polyp is bigger than 10 millimeters, specifically in the right colon, we worry about those genetic mutations.
And for adenoma.
If an adenoma gets bigger than 3 centimeters, the risk increases dramatically. The statistic in Baily and Love is that once an adenoma hits 3 centimeters, there is a 1 in 3 chance it's already turned into invasive cancer.
Wow, 1 in 3. That's huge. Size matters.
It absolutely does.
Now we have to talk about the genetic syndromes, the family tree. This is high-yield exam material. Let's start with FAP, familial adenomatous polyposis.
Visual anchor here, a carpet. We are talking hundreds, sometimes thousands of adenomas coating the inside of the colon.
A carpet of polyps.
Exactly. If you see fewer than 100, strictly speaking, it's not classic FAP.
And the genetics behind this carpet.
It's the APC gene on chromosome 5. It's autosomal dominant. If you have the gene, your risk of cancer is effectively 100% by age 40 if we don't operate.
Oh, 100%.
You almost never see a person with FAP keep their colon past their 30s. The treatment is a prophylactic colectomy.
But FAP isn't just about the colon, is it? The book mentions these weird extra features.
Yes, Gardner syndrome features. It's a constellation. You get desmoid tumors in the abdomen, which are these rock-hard fibrous tumors.
Ooh.
You get osteomas, bony lumps on the jaw or skull, and you get CHRPE.
CHRPE. That's an acronym I don't know.
Congenital hypertrophy of the retinal pigment epithelium. Basically little black spots on the back of the eye.
So an eye doctor might pick this up first.
Potentially. If you see a young patient with jaw lumps and a family history of bowel issues, think FAP.
Okay, let's contrast that with Lynch syndrome, or HNPCC.
Lynch is sneaky. In FAP, the mechanism is a broken growth regulator. The APC gene is the brake pedal, and it's broken.
Right.
In Lynch, the mechanism is a broken spell checker.
The spell checker.
Yes. The DNA mismatch repair genes -MLH1, MSH2. When your cells divide and copy DNA, they make typos. Usually, the mismatch repair genes fix those typos. In Lynch, they can't, so the typos accumulate.
And what does that look like clinically? Not a carpet?
Not at all. Lynch patients don't have a carpet of polyps. They might only have 1 or 2. But because their spell checker is broken, those few polyps transform into cancer incredibly fast.
So that's the rule of thumb.
FAP is about quantity, Lynch is about speed.
And for Lynch, we use the Amsterdam criteria to diagnose it. The 3-2-1 rule.
That's the one. 3 relatives with colorectal cancer. 1 must be a first-degree relative of the other 2.
Okay.
2 successive generations affected and 1 diagnosed under the age of 50.
3-2-1. Got it. Quick check-in question. If I'm looking at a colonoscopy report and it says carpet of polyps, am I thinking FAP or Lynch?
Carpet always equals FAP. Lynch is the sniper. FAP is the machine gun.
Clear as day. Let's move to section 3. The big C, colorectal carcinoma. Baily and Love describes the adenoma carcinoma sequence. It's like a stepladder to cancer.
It is. It's a progression of genetic hits. It takes time. You start with a mutation in the APC gene that initiates the polyp.
Step 1.
Then you get a KRAS mutation that makes it grow bigger. And finally, P53 gets knocked out.
P53 is the guardian of the genome, right? The one that's supposed to stop this.
Exactly. It's the cell's suicide switch. If a cell goes bad, P53 kills it. Once P53 is gone, the cancer cells are immortal. That's when it becomes invasive.
Now, clinically, this is fascinating. The presentation of colon cancer depends entirely on where the tumor is, left side versus right side.
This is a classic medical school distinction, but it holds up in practice. Let's start with the right side, the cecum and ascending colon.
You call this the silent tumor. Why?
I do. Think about the anatomy. The cecum is wide, it's spacious, and the stool there is liquid because water hasn't been absorbed yet.
Right, it's basically a slurry.
Exactly. So a tumor can grow quite large without blocking anything. It doesn't cause constipation, it doesn't cause pain, it just sits there.
What does it do?
It just bleeds. Quietly, slowly, a little bit every day. The patient becomes anemic, they present with fatigue, breathlessness, maybe some angina because of the low hemoglobin.
So an elderly patient with new iron deficiency anemia.
Has right-sided colon cancer until proven otherwise. That is the golden rule. You cannot just give them iron tablets and send them home. You have to look in the cecum.
Okay, now contrast that with the left side, the sigmoid and rectum, the noisy tumor.
The environment is different, the pipe is much narrower here, and the stool has had all the water sucked out of it, so it's solid.
So even a small tumor can cause a blockage.
Right away. These patients present with noise.
What kind of noise?
Symptoms.
Yeah.
Change in bowel habit. Constipation alternating with diarrhea. Overt rectal bleeding bright red blood. Or full-blown obstruction. They notice it much earlier than the right-sided ones.
And visually, on a barium enema, you get that classic sign.
The apple core lesion. The tumor constricts the bowel in a ring looking just like an eaten apple core.
Right side is silent, spacious, and anemic. The left side is narrow, noisy, and obstructive. Perfect.
Got it.
Let's touch on staging. We have TNM, which is the international standard, but exams still love Duke's classification. It's so simple.
It is elegant in its simplicity. Dukes A. The cancer is inside the wall, hasn't gone through the muscle. Excellent prognosis. A for, all right,
Okay.
Dukes B. It has breached the muscle wall. B for breaching. But no lymph nodes involved.
Still pretty good.
Still pretty good. Dukes C. It has spread to the lymph nodes. C for concern. This is where adjuvant chemotherapy comes in.
A is in, B is through, C is nodes, and D, is there a D?
D usually implies distant metastasis, liver, lungs. D for dreadful.
Okay. Knowing the stage dictates the surgery. We talked about the high tie, but what is the actual operation? What's it called?
For a right-sided tumor, we do a right hemicolectomy.
Hemi meaning half.
Right. We take the cecum, ascending colon, and part of the transverse. We take the ileocolic and right colic arteries. Then we join the small bowel, ileum, to the transverse colon. And for a left-sided tumor, a left hemicolectomy or a sigmoid colectomy, we take the left side, do that high tie of the inferior mesenteric artery we talked about, and join the descending colon to the rectum.
But sometimes you can't join them right. Sometimes it's an emergency.
That brings us to the acute presentation. About 20% of colon cancers present as an emergency, usually obstruction. The bowel is blocked, swollen, and angry.
Can you operate then? It sounds risky.
You have to, but it is risky. However, Baily and Love mentions a fantastic option, a bridge to surgery. The stent.
Like a heart stent in the bowel.
Similar concept. You put a self-expanding metal mesh tube through the tumor via a colonoscope. It expands, opens the blockage, and lets the patient poop.
Oh.
This buys you time. You can optimize their nutrition, clear the bowel, and then do the surgery electively a few weeks later. It turns a high-risk emergency surgery into a lower-risk planned procedure.
That sounds like a game changer. Let's verify our listeners' instinct here with a case study scenario.
Go for it.
Imagine a 72-year-old man walks into your clinic. He has absolutely no tummy pain. His bowels are regular like clockwork, no diarrhea, no constipation. But he's feeling tired. His wife says he looks pale. His blood test shows low hemoglobin. Why is a colonoscopy mandatory?
Because of the silent right side, he has no bowel symptoms because the right colon is wide, but that fatigue and anemia are screaming that he is bleeding from somewhere.
So that's the only clue.
It might be the only clue. You must rule out a vesical cancer. If you just give him iron tablets and send him home, you might miss a curable lesion until it's too late.
Powerful stuff. Okay, section 4, the inflamed gut. We're talking about Crohn's or ulcerative colitis today. That's a massive topic for another day.
A whole other deep dive.
We're talking infective causes, the usual suspects.
The most common one in the UK and resource-rich countries is Campylobacter, usually from undercooked poultry.
The Barbic classic.
The Barbic classic. It causes bloody diarrhea and pain, but usually settles on its own.
Then there's the one everyone fears in the hospital, C. diff.
Clostridium difficile. This is the hospital bug. It usually happens after a patient has been on antibiotics, specifically cephalosporins or clindamycin.
Why then?
The antibiotics act like a forest fire. They burn down the healthy trees, the good gut flora. And C. diff is the weed that grows back in the ashes.
And the visual anchor for C. diff, what do you see on a scope?
Pseudomembranous colitis. If you look inside, you see these yellow plaques or membranes stuck to the wall of the gut. It looks like splashes of creamy yellow paint.
Huh?
And the smell, well, once you smell C. diff diarrhea, you never forget it. It has a distinct horse-stable quality.
Vivid. And treatment.
Stop the offending antibiotic immediately. Then give oral vancomycin or metronidazole.
Then there is amoebiasis. This feels a bit more tropical.
Entamoeba histolytica. It's common in tropical climates, but you see it in travelers. It causes flask-shaped ulcers. The ulcer has a narrow neck on the surface, but widens out deep in the tissue, like a laboratory flask.
Is there a surgical trap here? Oh, don't do this.
A huge one. The critical surgical rule is, do not operate blindly on amoebic colitis. The bowel is described as being like wet tissue paper.
Wet tissue paper.
It is incredibly friable. If you try to sew it, the stitches just rip right through. It falls apart in your hands. You treat this with metronidazole, not a scalpel, unless they perforate.
That is a terrifying image for a surgeon.
Yeah.
Let's talk about ischemic colitis again. You mentioned the watershed area at the splenic flexure.
Yes. The symptoms here are classic but tricky. If it's a sudden clot, an embolus blocking the SMA, the patient has pain out of proportion to physical signs.
What does that mean exactly in practice?
It means they are screaming in agony. They look terrified. But when you press on their belly, it's soft. It doesn't feel rigid yet.
Why not?
That's because the bowel is dying from the inside out, but the outer layer hasn't inflamed the peritoneum yet. If you wait until the belly is rigid, it's often too late. The bowel is dead.
And is there an X-ray sign for this ischemia?
Thumb printing. The mucosa gets so swollen with edema and blood that it pushes into the lumen. On the X-ray, the gas shadow looks like someone has pressed their thumb along the wall of the colon.
Thumb printing equals ischemia. Got it. Moving on to section 5. Pockets of trouble. Diverticular disease. This is bread and butter surgery, isn't it?
It is extremely common. The concept is simple. It's a blowout.
A blowout.
Imagine a car tire where the rubber tread is worn down. The inner tube starts to bulge through the weak spots in the rubber. That's a diverticulum. The mucosa, the inner tube, pushes through the muscle, the tread.
And where are the weak spots in the colon wall?
Specifically where the blood vessels penetrate the muscle wall to supply the lining. That is a structural weakness.
Ah, and that's also why diverticular bleeds can be so heavy.
The hole is right next to an artery. Exactly.
Baily and Love links this directly to diet.
The Western diet. Low fiber. Low fiber means small, hard, dry stools. The sigmoid colon has to squeeze incredibly hard to move those rocks, generating high pressure. Laplace's law comes into play here. That high pressure blows out the pockets.
When these pockets get infected, it's diverticulitis. And we use the Hinchey classification. This is the ladder of containment. Walk us through the rungs of the ladder.
Right. So Hinchey the sixth. You have a small abscess just near the colon. It's contained. The body has walled it off.
Okay, manage on.
Hinchey the second. The abscess is bigger and has extended into the pelvis. But it is still an abscess, a collection of pus.
It's still contained, but a bigger problem.
Hinchey the third. Purulent peritonitis. The abscess has burst. The containment has failed. There is pus everywhere in the belly.
Not good.
And Hinchey the fourth. Fecal peritonitis. The bowel itself has perforated freely. There is poop everywhere in the abdominal cavity. This is the worst case scenario.
So I is a spot, D is a pool, third is this pus versus poop. How do we decide when to operate?
Hinchey and Certain 2 can often be managed without cutting. We give antibiotics, or a radiologist can stick a drain in to suck out the pus. But 3rd and 4, that's an acute abdomen. You need to wash that out.
Right.
And for Hinchey the fecal peritonitis, we classically perform the Hartmann's procedure.
Break down the Hartmann's for us. Why is that the go-to for these disasters?
Imagine you are in an abdomen filled with pus and feces. It is a septic swamp. The tissues are swollen, angry, and covered in bacteria.
Okay.
If you cut out the bad piece of sigmoid colon and try to sew the two healthy ends together right there, that joint, the anastomosis, will almost certainly leak.
Because the tissue is so unhealthy, it won't hold stitches.
Exactly. It won't heal. And an anastomotic leak in that environment is fatal. So we apply the principle of containment. We cut out the bad part. We sew up the bottom end, the rectum, and leave it inside. That's the rectal stump.
Okay.
Then we take the top end, the descending colon, and bring it out through the skin as a colostomy.
So the patient wakes up with the bag, but the septic source is gone, and there is no risky joint to leak.
Exactly. It's a bailout operation. The mantra is, don't sew in a pool of pus.
And you can reverse it later.
You can always reverse the stoma later, months down the line, once the patient is healthy and the inflammation has subsided.
Checking question. Why is a Hartmann's procedure preferred over primary anastomosis in Hinchey IV diverticulitis?
Because the risk of leak is too high, you need to divert the stream to keep the patient safe.
Section 6. Twists, turns, and vascular anomalies. Let's talk volvulus. This is the bowel twisting on itself.
There are two main players here, sigmoid and cacal.
Okay.
Sigmoid volvulus is the classic nursing home presentation. You have an elderly patient, often with Parkinson's or on psychiatric meds that cause chronic constipation.
Right.
The sigmoid colon gets longer and longer over years, becoming floppy and redundant. Eventually, it twists on its mesentery.
And the X-ray sign for this is famous, isn't it?
The coffee bean sign. It looks like a massive coffee bean rising out of the pelvis, filling the whole abdomen. It's unmistakable.
And the treatment is surprisingly low-tech initially. You don't just rush to the OR.
No, you don't rush to cut. You put a flexible sigmoidoscope or a flatus tube up the rectum. You navigate past the twist and whoosh!
A gush of air.
A massive gush of air and liquid stool. You basically let the air out of the tire. It untwists the bowel and decompresses it right in front of your eyes.
But does it stay untwisted?
Often not. It tends to recur. So usually you decompress them, prep them, and then do surgery later to remove that floppy loop. But the tube saves you from an emergency operation.
Okay, now contrast that with cacal volvulus.
Cacal volvulus is a different beast. It happens in younger patients, often 30s or 40s.
Younger. Why?
It's due to a congenital lack of fixation. The right colon isn't stuck down properly to the back wall. When it twists, it cuts off its blood supply very quickly.
Can you use the tube trick for that one?
No, you can't reach it easily, and the risk of gangrene is far too high. Cacal volvulus needs surgery immediately, usually a right hemicolectomy.
So sigmoid, old, coffee bean, tube first, cacal young, surgery now.
Perfect summary.
Now what about angiodysplasia? This is those little vascular malformations.
These are like little spiders of dilated veins in the submucosa, usually on the right side of the colon. They are a common cause of painless but heavy rectal bleeding in the elderly.
And the interesting link here is Hayes syndrome.
Yeah.
This is the connection with the heart, right? Aortic stenosis.
Exactly. Aortic stenosis plus angiodysplasia. It's a fascinating mechanical issue. The tight, calcified aortic valve is like a meat grinder.
A meat grinder.
As blood shoots through it at high velocity, it creates shear stress that uncoils and grinds up a clotting protein called von Willebrand factor.
So the clotting factor gets physically destroyed by the heart valve.
That's the theory. It's an acquired von Willebrand disease. Because the clotting factor is broken, these little fragile veins in the gut bleed more easily.
So if you fix the heart valve,
the gut bleeding often stops. It's a fantastic systemic link. It reminds you that the colon isn't an island.
Last practical point before we wrap up. Stomas. We mentioned the Hartmann's colostomy, but for the medical student listening, what is the practical difference between a loop stoma and an end stoma?
An end stoma is what it sounds like. You cut the bowel and the end comes out. It has one opening. This is usually permanent or at least long-term, used in Hartmann's or after removing the rectum entirely.
One-way street. And a loop.
A loop stoma is usually temporary. You pull a loop of bowel out through the abdominal wall, make a slit in the side of it, and use a plastic rod to keep it from slipping back in.
So it has two openings.
It looks like one big stoma, but it actually has two openings close together. One producing stool, the proximal one, and one leading down to the inactive bowel, the distal one.
Why do we do that? What's the point?
To protect a join further down. Say we removed a rectal cancer and sewed the colon to the rectum. We're worried that a join might leak. So we create a loop ileostomy upstream to divert the traffic.
I see.
It allows the joint to heal without poop flowing over it. Once it's healed, we can just close the little slit in the loop and drop it back in. It's a much smaller operation.
And geography matters. Where do they sit on the belly?
Yes. An ileostomy is usually on the right. It produces liquid enzymatic stool, very corrosive to the skin, so we make it spouted. It sticks out like a spout, so the liquid drops directly into the bag.
Right side spout.
A colostomy is usually on the left. The stool is solid and less irritating, so we make it flush with the skin.
Right spout liquid. Left flush solid. Expert speaker, we have covered an immense amount of ground. From the drawstrings of the Taenia coli to the spell checker of Lynch syndrome, the septic swamp of the Hartmann's procedure, and the coffee bean sign.
We have. This chapter is a cornerstone. If you understand the anatomy, the blood supply, and the way these pathologies present, you can manage a huge chunk of the acute surgical take.
It all connects.
It really does. You won't be surprised when you see that patient with the soft belly screaming in pain. You'll know what's going on.
To wrap up, let's go back to the text one last time. Baily and Love mentions something intriguing in the etiology section. It talks about fusobacterium.
It does. It raises a provocative thought. We know diet affects cancer risk, but the mechanism might be the microbiome.
The gut bacteria.
Right. Fusobacterium nucleatum is found in high levels in colon cancer tissue. It seems to drive inflammation and adverse gene methylation.
So if diet drives the flora and the flora drives the cancer.
Are we looking at a future where we treat or prevent colon cancer not just with surgery, but with, I don't know, probiotics or even fecal transplants?
Like we do for C. diff.
Exactly. Could microbiome manipulation be the next frontier in oncology? It's an interesting thought.
That is definitely something to mull over. For now, your homework is simple. Open Baily and Love, Chapter 77. Look at the pathology images. Look at the apple core sign. Look at the carpet of polyps and FAP. Lock those images in your mind.
The text is the map, but you have to walk the territory. Go read the chapter.
See you in the next deep dive.